scalene hypertrophy, inflammation, and spasm. These patients do have low-grade repetitive trauma or age-related postural changes or congenital variation of anomalies. See, the demographics are present in 0.3 to 2% of the general population, and the most importantly, it's more common in women, and the age range is typically between 25 to 40 years. So how do you diagnose? You should recognize the pattern, find out whether it's arterial, venous, or nervous involvement. Check for the history, symptoms, signs. Look for any other physical abnormalities. Look for exacerbating factors. Look for any changes of effort thrombosis. Usually venous thoracic outlet do present when patients have effort thrombosis. In case of arterial thrombosis or arterial compression in thoracic outlet syndrome, the patients will present with digital or hand ischemia, cutaneous ulceration, emboli, forearm claudication. They do present with pulsatile supraclavicular mass or bruit suggesting subclavian artery aneurysm. When you examine, check for any pulsatile mass, bruit, swelling, cyanosis, blanching, discoloration, petechiae. Need to identify the trigger points, do a peripheral nerve exam, check for carpal tunnel, cubital tunnel syndromes, rule out unbound nerve entrapments, check for the muscle strength, weakness, and loss of muscle mass. How do you diagnose? There are certain provocative tests. First one is the Adson's manual. On a deep inspiration, ask the patient to keep the neck rotated towards the affected side and look for absence of radial pulse. Similarly, there is the Wright's test. Here you turn the neck away from the affected side and look for absence of the distal pulse. Third one is the elevated arm stress test. This is more correlative compared to the other two tests, where they ask the patient to take up a military position with the chest elevated and arms by the side abducted, and ask the patient to do rapid opening and closing of fists and do the test up to 3 minutes. The other important diagnostic features will be by help of electromyography, do nerve conduction studies, check for somatosensory evoked potentials, and rule out other diseases or compression syndromes. The anatomic studies will include duplex ultrasound and a normal chest radiograph to rule out cervical rib or abnormal transverse process of the cervical vertebrae. CT angiography, MR angiography, MR venography help in assessment of arterial and venous TOS. You look for the artery patency, look for stenosis, thrombosis. So typical example of an arterial TOS where there is a post-stenotic dilatation of the subclavian artery. So venous TOS where a lot of collaterals around. So to summarize, neurogenic TOS is the most commonest of these three variants, presents in 95% of the patients. Etiologies being a repetitive neck trauma. Predisposing factors will be cervical rib, congenital bands, scalene triangle muscle variations. These patients will require non-surgical treatment at the first go. It's physical therapy, it's physiotherapy. If it's failing, then consider surgical resection by way of scalenectomy with or without rib resections. In case of venous TOS, consider first rib resection, subclavian vein venolysis, or postoperative angioplasty if required. In case of arterial TOS, always surgical management is the only treatment available. So what are the complications which can happen following surgery for thoracic outlet syndrome? Phrenic nerve injury, avulsion of thyroid cervical trunk, pleural injury leading to pneumothorax and hemothorax, brachial neuralgia, injury to brachial plexus, injury to lymphatics leading to chylothorax, and Horner syndrome. Small word about subclavian steal syndrome. When the first part of the subclavian artery is blocked, what happens? The blood can flow across the circle of Willis. There's a low pressure system developing over here, so the blood preferentially flows over into the vertebral and goes to the arm, thereby decreasing the flow to the posterior circulation, leading to dizziness and visual symptoms.